The first neurological test we are doing for the lumbar spine is the slump test, and if you're trying to decide if there's neurological involvement. So this test puts tension on the dura, and you want to make sure you test the uninvolved first before the involved limb. So the first thing you do is instruct the patient to put their hands behind their back and slouch down and bend their neck chin to their chest. Here you're checking if this reproduces their symptoms or complaints, and down their leg. You would hold their head still, but make sure not to push down, and test one leg at a time. Then you will help passively extend their leg, and if the patient still doesn't feel any tension, then increase the stretch to the dura by dorsiflexing their foot. And if now the patient feels their complaints and symptoms, I can now tell them to look up to the ceiling and then ask if that changed their symptoms at all. If she says it's better, then that's a positive test because we have let the stress off the dura, but if there is no change, it's probably just hamstring tightness. This next test is a sympathetic slump test, which is similar to the standard slump test but with bias for the thoracic spine. When examining the thoracic spine and having complaints from our patients that sound more autonomic, such as sweating, and it sounds like you're getting the sympathetic nervous system involved here, you can bias the normal slump test to be more towards the thoracic spine because if the sympathetic chain is running along this area, so you're trying to stretch that. So you're going to have the patient in a long sit, and just like the standard slump test, they will slouch down with their hands behind their back and their chin tucked. And if I am checking the right side, I will have the patient bend their right knee and I will stand on the opposite side. So I'll have the patient bend the right side and then go ahead side bend to the left and then also rotate left towards me. And so have the patient with their head down and ask the patient now to slowly straighten out their leg. And if the patient complains, that's as far as they can go. You now ask the patient to look up at the ceiling and ask if that changes anything. You will sometimes get their symptoms back in their leg or in their spine, but it will also elicit the sympathetic response, which would be a positive test. Another neurological test to check the dura for the lumbar spine is the straight leg raise test. So you can grade your straight leg raise test on the side that you're next to. So if the patient complains of pain or symptoms on the left, you will stand on the left side, and then if they're complaining on the right side, you will be standing on the right. So the patient is supine, and then you are going to passively lift the patient's leg up until they complain of their symptoms. Then you will slightly lower that down until the pain or symptoms go away. And then next you dorsiflex the foot to re-elicit those symptoms. And here, if the patient says that their symptoms are back, you now ask the patient to lift their head, their chin to their chest. Now here you ask if that changes anything for them, and if they say it's worse, that's a positive test because we just increased the stretch on the dura. If the patient feels better with the chin tucked to their chest, oftentimes the hamstrings are tight and that's the stress that they are feeling. That is the standard straight leg raise test. But there's also a cross straight leg raise test when you are lifting the leg you are closest to, but the patient's complaints are on the opposite side. And when you perform the straight leg raise test and dorsiflex the foot and have them put their chin to their chest, the patient would say that the position has reproduced their pain on the leg that is flat on the table, so their opposite side. This is a cross straight leg raise test, and the prognosis for this is normally worse because it's more associated with a large central disc protrusion. This is another neurological test called the femoral nerve traction test. So with this, we are tractioning the femoral nerve, and this would be indicated if a patient is complaining of numbness and tingling and pain in the femoral nerve distribution, which is in the anterior thigh region. So we'll have the patient side lying with the affected leg facing up. We're going to stabilize at the hip and then start traction with that femoral nerve. So we're going to bring the hip into some extension and gradually bend their knee into flexion. If this produces the patient's complaints of pain or numbness and tingling, when you bend and let a little bit go and bring the leg back out slightly into extension, and then the pain goes away, that would be a positive test. Now we'll be performing the passive lumbar extension test. So this is a test for lumbar spine instability. So there's two different ways you can do this. You can grab a hold of the patient's legs and you can physically provide the extension, lifting the patient's leg off the table approximately 1 foot above the trunk, or you can also use the treatment table to help you do the work. If your table can adjust in segmental angles, you can position the patient's hip to align with the crease of the table where you're going to have the angle into extension. So we are going to be doing it the physical way because this table does not bend like we need it to. So now you will lift the patient's legs off the table, like I said, approximately 1 foot above the trunk. And then with this, if the extension produces the patient's symptoms of heaviness and then resolves when the patient's legs are lowered back down to the table, this is a positive test. So this is the prone segmental instability test. So you can use this if you are checking to see if the patient has any lumbar spine instability. So for time's sake for this video, we have already identified that their complaints are around this area. So we will say that we are suspecting the instability to be around the L3, L4, L5 region. So once you have done that, you position the patient on the edge of the table, facing down, feet on the floor, and you are going to palpate at those levels that we are suspecting being via the PA glides. So I am going to find her iliac crest, work my way around into the L5 region. You do your PA glide. The patient has no complaints here. Then you move to the superior spinous process to L4, and then that's when the patient feels their pain and their symptoms come on. So now you need to keep your hand where it is and ask the patient to now lift both their legs off the ground and hold. Now you will perform another PA glide at the same segment but with the patient's legs off up the floor. If the patient says it feels better now, my pain is less, that is a positive instability test because when she lifted her legs up, she activated her back muscles and her thoracolumbar fascia to stabilize her spine. If when the patient lifts their legs up and they still feel their symptoms, then that is a negative test. So now I'll be performing the H&I test. You can use this test if you want to get the sense of the quality of the motion, how they can control their lumbopelvic rhythm, or if you're concerned about any instability. While the patient is going into these positions, you're going to see if the patient is going to reproduce any of their pain during this. So you can start and explain to the patient that they're going to imagine a capital H, and you are going to draw that H with your body. So we tell our patient to bend to the left first as we are making one side of the capital H, then come forward into flexion. While staying on that side, now bend back into extension, and then come back to the middle. Now we will make the other side of the H and side bend to the right, forward, and then back again to neutral. As you are doing this, you want to observe and assess their movement and watch from the side and their back to look for any loss of control or shake or any aberrant movement and look to see if they are symmetrical. Now they're going to make the capital I. So this time they will bend forward first. Then while staying bent forward, staying in the flex position, they're going to move to the left and then to the right, which is the bottom of the capital I. Now they will come back up and now bend backward into extension and then to the left and then to the right. We are observing and looking for the control and quality of motion. So this is the test for anterior spine instability with an anterior shear. So if you are suspecting a problem at, let's say, L4, L5, we are going to palpate the iliac crest, work our way into the spinous process, and find L4 and L5. So we are going to put your finger onto the superior segment, which is L4 in this case. You have the patient positioned side lying in about 70 degrees of hip flexion and 90 degrees of knee flexion. Now you're going to use your body and your hips to push against their knees while still stabilizing at the superior segment of L4. When you push your hips into their knees, this will shift L5, the inferior segment, posteriorly, which will shift L4 into an anterior glide. So this produces an anterior glide of L4 on L5. Looking if the patient's complaints of pain or heaviness are reproduced in the legs or in the spine. You should have little or no motion, but if you do get excessive motion, that would be a positive test. Another test we can do for instability is a test for posterior instability, posterior shear. You're going to have the patient seated at the edge of the table facing you, and you will instruct the patient to bend and flex their elbows and place their forearm on your shoulders. Let's say we are checking L3, L4, so I will find L4, which is the inferior segment, stabilize there with my fingers. And then you instruct your patient to push their arms into your body, which will push them away from you. This will create a posterior glide of L3, the superior segment, and this is a positive test if you can reproduce their symptoms and heaviness in their legs. This is the quadrant test. If you are considering joint dysfunction, specifically for the facet joint, you can do this test. If you have tried straight plane flexion and extension and were not able to really reproduce the symptoms and complaints of the patient, you can combine motions of extension, side bending, and rotation. So you will test one side first and instruct the patient to use their right hand and place it on their back of their right thigh. And now they will slowly slide their hand down their leg. As you can see here, they are now in combined extension, side bending, and rotation to see if that will reproduce their symptoms or complaints. After testing the one side, you will then tell them to get back up and then test the other side. So now the patient will take their left hand, place it on the back of their left thigh, and the same thing, slide it down their leg, and then come back up. It'll be positive if you reproduce their complaints. So now I'll be performing the bilateral straight leg raise test, also known as the Milgram's test, and this is an assessment of abdominal muscle strength. So the patient lies supine and is going to actively lift both their legs fully extended simultaneously off the table, and their legs are going to be lifted around 2 to 4 inches off the table, holding the position for up to 30 seconds. So according to the McGee text, this is considered a positive test if the limbs or the affected limb cannot be held for 30 seconds or if they ever produce their symptoms. And according to the Dutton text, the inability to perform this test due to muscle weakness is not considered a positive finding, but it should still be noted. So this is called the Stork Standing Lumbar Extension Test. This test is used if you're assessing for joint dysfunction. Here you'll have your patient standing on one leg and extending their spine while balancing on that leg. You will perform this on both sides. It is considered a positive test if pain is reproduced in the back, and that can be associated with a pars interarticularis stress fracture or spondylolisthesis. If standing on the ipsilateral leg causes more pain, the stress fracture is unilateral. You can also combine rotation with extension, and if the pain is reproduced, that could possibly indicate facet joint pathology on the side to which the rotation occurs. So this is the 90-90 straight leg raise for hamstrings. You can perform this test if you have any problems in the lower quarter as part of your general exam. You want to check the length of these muscles as they can contribute to problems in the lumbar spine, lower quarter. So to test for hamstring length, have the patient lying supine and bring the patient into 90 degrees of hip and knee flexion. Then you passively extend the patient's leg. You want to compare both left and right sides to look for symmetry. Normal hamstring length is if the patient can get to about 20 degrees of full knee extension, and if you are unsure of the degree, you can use a goniometer to measure to see if they are within that 20 degrees. If you are not within that range, that would be considered tight hamstrings. So now we are going to be performing the Ober test. You can use this test to check for IT band tightness. The patient is side lying with the tested leg straight, lat side up, and you can bend the bottom leg. Just make sure that they are rolled over their greater trochanter on the side of their leg that is on the table. You then want to stabilize the ilium and keep their knee straight, and then bring their leg back into some extension, and then let the leg drop down to the mat. Since you see she is past the table, we don't see any tightness with her, but if her leg was raised and doesn't come down all the way down to the mat, that would be tightness for her IT band. This is the rectus femoris test. This is an anterior muscle length test, so we'll use this if you're thinking that there is some sort of length shortening of the rectus femoris, which looks similar to the Thomas test. So you have the patient seated at the very edge of the table and have them roll back onto the table, bringing their knees up to their chest. Then you will tell the patient to hold on to their left knee with both hands, since I will be testing the right side, and I would ask them to give me full control of the right leg. I will now stabilize the ASIS and control the right leg down to the floor. So now once the patient goes as far as they can, you can now bend their knee. And as you bend their knee, if the patient's leg pops up off the table, you then know that it is a problem with the rectus femoris length. Now we are testing another anterior muscle length test called the Thomas test. This is to check for hip flexion tightness. You have the patient supine on the table, and if you're testing the right side, you'll have the patient bring their opposite leg to their chest and have them hold on. This is looking more for iliopsoas and not your rectus femoris. So once they grab hold for their leg, pull it to the chest, you will see with her that she does not have any space under her thigh and it doesn't come off the table. But if you see this and their thigh pops up off the table, that may be hip flexor tightness issue. So now we are performing the sign of the buttock test. If you're examining a patient with back or hip complaints and trying to differentiate, you can perform this special test. You're going to have the patient supine, and similarly to the straight leg raise, you're going to lift their leg up until they feel their complaints. And if they're having some hip pain, you're now going to take the stress off the hamstrings and bend their knee. So now you'll see if you can move the patient further. You should be able to move them even more because now you put the hamstring on slack. But if you can't move them further with the knee bent and pain is limiting them, that is considered a positive sign of the buttock. That's typically indicative of something like a fracture or a neoplasm. So if you do get a positive test, you would want to refer this patient out for more and medical assessment. So to check for instability in the thoracic chain, we can do what's called the sitting arm lift test. So you have the patient sit and raise their arm without stabilizing the suspected levels of the thoracic spine, and then you compare it when you do stabilize. So the patient is sitting with their back facing you, and then you're going to ask the patient to lift their arm overhead, but test the uninvolved side first. You are observing to see if they have control and if they substitute, so we're going to say that the right side is the involved, so we'll test the left first, which is the uninvolved. You will see that the patient is lifting and they have control, and it's the unaffected side, and then you'll have them put it down, and now we're going to assess the right side. So now here you will see that the patient will either complain of heaviness or mid-thoracic pain and doesn't control it well, or they will say that it's hard to do. So also remember, it's not necessarily a pain generator. It could be, but not always. So then you have to bring their arm down, and then for the sake of time, we will say that we've already found the levels that we suspect and have determined to be the area that might be involved by palpating those thoracic rings at the specific levels with our PA glides, or the patient's complaints of pain. So now you'll go in and stabilize the thoracic area and the rib associated with that and ask her to raise her arm again. And if that motion lessens her symptoms or improves the quality of motion or alleviates her symptoms, that is a positive test. So now we are going to be doing the prone arm lift test. This test is similar to the sitting arm lift test, but lying prone, and the patient is now lifting their arm against gravity and with a stabilized spine. This might be a person who complains of heaviness and it's difficult to use their arm going into more overhead activities. So you will test again the uninvolved side first and ask them to raise that, and then you would go ahead and repeat that on the involved side. When raising the involved side, and this reproduces the patient's complaints, have them lower back down, and like the sitting arm lift test, you will go over the area you are suspecting and stabilize the spine and the ribs. After you have that stabilized, you ask again for them to raise the involved side and look for improvement of motion or control or decrease in symptoms, and that will be considered a positive test. So this is the reflex hammer test, and this is a special test to screen for bony integrity and a potential fracture. So this test is used if there has been any trauma to the posterior elements of the thoracic vertebra. So if a patient has a history of their trauma to the spine or has significant osteoporosis or complaints of thoracic spine pain and you're concerned for a potential fracture, you could perform this test. The patient is sitting on the table and you're either going to use your reflex hammer or your fist, but we will be using the reflex hammer to tap over each spinous process to see if the pain or muscle spasm is provoked. If so, a fracture may be suspected. So if that produces tenderness and the patient has a history of trauma, you may want to refer this patient out to help rule out the fracture. You can also do this with a closed fist. With this, the examiner may also percuss the paravertebral tissue, which, if pathological, will go into spasm. So now we'll be doing the Murphy's percussion test. This is a special test to help screen for a potential kidney problem. The patient is lying prone, and you're going to have a flat hand over the costovertebral angle, and then you're going to use your fist to provide a percussive thump down onto your flat hand. You will compare the uninvolved and the involved. This is considered a positive test if it reproduces the patient's costovertebral tenderness or back or flank pain, indicating renal involvement.